With all your permission.
All right.
So we are good to go now, ma'am?
Yeah.
Okay. I request the attention of the faculties and delegates. I will take a few minutes of yours and let me introduce me and the delegates member. Good evening. I'm Ankita from Planet. Planet is very proud to be a part of this digital webinar organized by Oncology Integrated Society. And the topic of today's session is CA Ovary Update. Now, let's begin today's session, for which I would like to invite Dr. Deepthi ma'am to take over.
All right.
I would like to play a small video.
Hello, and welcome to all. Please switch off your mics. It's echoing. Just switch off your mic. Don't leave. All right. So to begin with, it's a proud privilege and a big honor for us to keep on putting up this webinar series, one of its kind, in the Oncology Integrated Society with Dr. Chaturvedi Cancer Hospital and Research Center Private Limited, Basharatpur, Gorakhpur, along with the technical assistant of Clarinet, which is a big platform for all the doctors and which is known for its own academic excellence. So today is the topic of ovarian cancer. And first we will talk about the preventive oncology in the beginning, and later we will talk about the recurrence of ovarian cancer. So preventive oncology is of ovarian cancer is very much essential because mostly ovarian cancer is diagnosed in later stages because there are no specific symptoms. And so by improving the prevention and early detection of ovarian cancer, it can be a very critical component of reducing the morbidity and mortality. So today we will be discussing the genetic and the non-genetic risks factors of the disease, along with the potential prevention strategies and the methods for early detection and screening of ovarian cancers by a learned speaker, Dr. Roli Purwar. She's a gynae oncologist. In particular, this chapter will identify a number of gaps in the knowledge related to identifying those women who are at highest risk of developing ovarian cancers. It describes several challenges to developing screening tests in the high-risk women, their families, and general population, and how these gaps in the knowledge or the basic biology of ovarian cancer can hinder the development of better methods to prevent ovarian carcinoma or detect them at the earlier stage of the disease progression. When it is not diagnosed early, it will relapse. It will be difficult to treat. It will short the longevity, though it can, in early stage, patient can live up to 90% or more. But when diagnosed late, in spite of the best efforts, in spite of the best surgeries, it will have a relapse. So later on, we'll be talking about the relapse story by ovarian cancer by Dr. He is also a very learned and eminent and renowned speaker, Dr. Gaurav Gupta, medical oncologist. So first, I'll tell you about our chairperson, Dr. A.K. Chaturvedi, who is the owner and proud owner of Dr. Chaturvedi Cancer Hospital. And he has many credits to his knowledge, many theses, and he has been past president of UPARI, and he has 40 years experience in treating the various types of cancers in the whole body, men, women, children, and all ages. Over to you, Dr. Chaturvedi. Today is the chairperson of this webinar.
Thank you, Dr. Deepti.
Thank you.
As you know,
Mute to nahi hai.
Thank you, Dr. Deepti. As you know, carcinoma ovary is second most lethal gynec neoplasia in the world, and it's the seventh cancer-related mortality around world. It is responsible for, and 70% of ovarian carcinomas, they relapse after primary cytoreductive therapy and definitive chemotherapy, first-line chemotherapy. So mostly they relapse. But the reason is because in early stages, we are not able to diagnose the ovarian carcinoma because it's a hidden organ. So whatever relapses are because of the cancer stem cells, and they play an important role in relapses. Today we have got eminent speakers, Dr. Roli Purwar. She will be speaking on screening for carcinoma ovary and its diagnostic tools. Dr. Roli Purwar, she did MBBS from SN Medical College, Agra. She did her MS from VM Medical College and Safdarjung Hospital, New Delhi. 2 years fellowship in gynec oncology in IMS BHU, Varanasi. She was senior resident in AIMS Delhi and AIMS Gorakhpur. She had 18 indexed publications with 2 meta-analyses. She won IASO Best Paper Award and had FOXI and ISO membership. So she will be speaking on screening for the ovary and its diagnostic tools. So Dr. Roli Purwar, over to you, Dr. Roli Purwar. Most welcome.
Thank you so much, sir, for giving me the opportunity to speak on this topic.
Right.
Ankita, please share her slides.
Sure, ma'am.
Ankita, please share. Okay, thank you.
Thank you so much for sharing my slide. Let us start. Please open the first slide. Today we are talking about ovarian cancer screening and diagnostic tools. First, we will just know what are the risk factors for CA ovary. There are basically 3 risk factors. One is reproductive, second is lifestyle and environmental risk factor, and third is family history and genetic risk factor.
Just instruct me accordingly when I have to be on the next slide,
Okay.
ma'am, please.
Okay, open the next slide. In reproductive risk factor, it's most common with 1 or more birth or use of oral contraceptive pills and breastfeeding. It causes 30 to 60% decrease in risk of ovarian cancer. In contrast, nulliparity, postmenopausal hormonal therapy, pelvic inflammatory disease, these all may increase the risk of cancer ovary. And the ovulation induction, as currently we are seeing in IVF, it may increase risk for borderline ovarian tumor. Next slide. Other lifestyle and environmental risk factor, that is obesity. There are studies showing it has inconsistent results because obesity is a confounding factor, which is associated with parity, oral contraceptive pills, menopausal status. Next is smoking. Smoking has shown that it has increased the risk of mucinous CA ovary, but decreases the risk of clear cell cancer. Talc had not been conclusively associated with neoplasm. Next slide. Coming to family history and genetic risk factor, as we know that BRCA1 and BRCA2 genotypes, it is associated with approximately 50% of all ovarian cancers. Next, with 2 or more, if you have 1 degree relative with ovarian cancer, there is increased risk of ovarian cancer. Lynch syndrome and other germline mutations like ATM, BRIP1, PALP2 genes, these are also associated with ovarian cancer. Next, coming to our screening, as we all know, change the slide. As we all know that cancer ovary, there is no standard recommendation for screening of cancer ovary if patient is asymptomatic. We can't screen because usually the symptoms that came in case of cancer ovary are usually generalized symptoms that can be associated with other diseases also, like bloating sensation, pelvic or abdominal pain, difficulty eating or feeling full quickly, urinary symptoms like urgency or feeling of bladder irritation. These are very common symptoms and these can be associated with other common causes. So usually these type of patients got ignored at such early stages because of their symptoms that came very generalized symptoms. Next modality, that is ultrasound, that is 2D ultrasound. We can use for screening TVS and TS, these transvaginal ultrasound and transabdominal ultrasound. These both are complementary to each other. Transvaginal ultrasound is considered superior to any other modality for routine use. It is the first modality of choice. Next is the transabdominal. If pelvic anatomy is distorted by previous surgery or mass is extending beyond the pelvis, or if transvaginal ultrasound cannot be done, then TAS can be given the priority. Next, if we are going to look for ultrasound in a female, we usually look for uterus size, shape, endometrial thickness, ovary size, shape. We look for tubes unless there's any tubal disease or other. Then we go to adnexa. Then what are the features that we have to look in adnexa? Please next. In any adnexal lesion, the following features should be determined, like size, architecture, solid, cystic, unilocular, multilocular, wall thickness, septations, papillary projections, vascularity. Next. Coming to 3D ultrasound, 3D ultrasound is superior than 2D ultrasound because we can measure volume of the lesion and there's better characterization of morphology, like demonstrating septa, cyst wall irregularities, papillary projections. And use of 3D ultrasound, it can improve the prediction of malignancy as compared to 2D ultrasound. Next. There is an IOTA analysis that is called International Ovarian Tumor Analysis. IOTA scoring, it is used to differentiate benign from malignant features. It has 2, that is logistic regression model and simple rules. So next, please, next. In logistic regression, it is a computed automatic system in which we enter certain findings are there and we have to enter and we can determine the risk of cancer ovary, whether it is low risk or whether it is high risk. Next. It is LR1 logistic. Next, there are 2 models. Make it next. Logistic regression 1 and logistic regression 2. In logistic regression 1 model, we have to enter the history and what are the examination findings and what is the, if previous any hormone therapy is given to the patient. But in second model, we have to enter the what is the age of the patient, what is actually ascites, maximal diameter of the, all the ovarian components are to be entered. Next. Then it's a computed report that came and we can determine if there's a low risk or high risk in cancer ovary. Next. Then coming to our next, this is the most simple that we used to study in our post-graduation time, like B, that is B and M. B rules and M rules. B rules are for benign and M rules are for malignant. So there are 5 benign rules and 5 malignant rules. Next. The 5 benign rules are there. That is a unilocular cyst. There is no. Next, there is unilocular cyst, and next, there's if the solid component is less than 3 mm, and if there is anechoic shadow is present. Next, fourth. Next, there is a multilocular cyst if it is less than 10 centimeter, and fifth, if there is a vascularity is if there is no vascularity. Next. Next. Coming to our M rules, there are also 5 M rules. Next. 1 is the irregular solid tumor. Next. ascites. Third, next, it is the papillary projections, that is more than 3 mm or multiple papillary projections. Next is irregular multiloculated cyst. Next, and if there's increased vascularity on color Doppler. So these are 5 M features and 5 benign features which we can differentiate the mass. It could be benign or malignant. Next. Next. Then this is the interpretation of iota rules. If it is benign, if only B features apply, malignant if only M features apply, and in conclusive, there are no both B and M features. Other workup needed to rule out malignancy. Next. Next. There's a study that is published in Human Reproduction Update, and it gives a sensitivity and specificity for these iota model. So as we can see that simple rules are more sensitive, and the logistic regression has a higher specificity to differentiate the benign and malignant masses. Next. Then coming to ORATS scoring, it is an ultrasound-based scoring that, as we see in breast, there is BIRATS scoring to differentiate if there's a grading from benign to malignant masses. Same as there is an ovary, that's ORATS scoring, and to differentiate benign from malignant masses. And ORATS has the principal, ORATS, it is developed by American College of Radiology in 2018, and it is the main goal is just to simplify and to maintain a lexicon that we can usually that we can use commonly everywhere. Next, so there are ORATS 1 to 5 grading is there. Next slide, please. Oh, the ORATS 1 to 5. There is a if it ORATS 1 to 5, we can just appreciate what is the risk of malignancy in each category. So one is the ORATS 1. ORATS 1, it is normal ovary. Normal ovary findings, like if there's a follicular cyst, if there's simple Graafian follicle or simple follicular cyst that is less than 3 centimeter, or a corpus luteum cyst, or any cyst that is less than 3 centimeter, it comes into normal category, and it has 0% likelihood of malignancy. Next is ORATS 2. It is less than 1% risk of malignancy. Like if any simple cyst, it is between 3 to 10 centimeter, whether in premenopausal or postmenopausal, or there is a unilocular cyst that is less than 10 centimeter. Another is classical benign lesions. Next slide. These are classical benign lesions, like cyst size should be less than 10 centimeter, like typical hemorrhagic cyst, dermoid cyst, endometriomas, or benign paraovarian cyst, peritoneal inclusion cyst, or typical hydrosalpinx. So these all cysts come under low risk category. Next is ORATS 3, that is low risk. It has less than 10% likelihood of malignancy. And in ORATS 3, we usually the cyst, if there's a unilocular cyst, but it is more than 10 centimeter, if it is typical hemorrhagic cyst, dermoid cyst, endometrioma, that is more than 10 centimeter, that is are present, but color scoring is 0 or 1. Then we can put them in ORAT. Next slide. Coming to ORATS 4, or from ORATS 4 to ORATS 4 and ORATS 5, these have the highest risk of malignancy. In ORATS 4, there is around 10 to 50% risk, and in ORATS 5, there's more than 50% risk of malignancy. So beyond ORATS 4 and 5, you have to refer the patient to gynec-oncologist. So the cyst characters which can be shown in ORATS 4 are multilocular cyst with the color vascularity increase, with a more solid areas, with the papillary projections more than 3 mm, and there are more than 4 in number, or there are solid areas with increased vascularity. So these type of cysts, they have a malignant feature. So we can differentiate them as a malignant masses, and they need a proper staging laparotomy. Next slide, please. Please put a backward slide. ORATs 5, these are the highest risk of malignancy. That is a unilocular cyst, more than 4 papillary projections, solid areas, increased color vascularity, if you have ascites, peritoneal nodules, or there are solid areas more than 80%. So these all are malignant features, and this goes towards the malignant case of CA ovary. Next. Then how we have to approach that? Primary workup is abdominal or pelvic ultrasound. CT and MRI have not given much priority in CA ovary, because if till CT and MRI are only used when we are sure it is a malignant ovary, and we have to differentiate certain features that it could be that what is the malignant potential of the mass. So USG is the basic modality for triaging benign or malignant masses. If ultrasound got indeterminate, then we will go for CT or MRI. And PET CT and MRI is only recommended by NCCN in indeterminate lesions. Next. Next. Then coming to next modality, that is CA125. CA125, as we all know, that is a glycoprotein produced by mesothelial cells of peritoneal cavity, pleural cavity, pericardial cavity, and it is elevated in epithelial ovarian cancer. In early stage cancer, it is expressed by 50%, and in advanced ovarian cancer, it is expressed by around 80% of tumors. Next, then we know that CA125 is a marker that can be elevated in certain non-malignant conditions, and it can also be elevated in certain non-gynecological cancers. So the non-malignant conditions are like cirrhosis, ascites, acute salpingitis, pancreatitis, endometriosis, as we have most commonly seen. Certain benign ovarian tumors, there's also. Next slide. And there are certain non-gynecological cancers like liver cancer, pancreatic cancer, biliary tract cancer that can also cause the raised CA125. So it is not a very sensitive marker for specifically for CA ovary. Next. Next is the risk of malignancy index. It is called RMI score. Next, RMI score consists of 3 features. That is CA125. There are certain ultrasound points and menopausal status. Ultrasound, there are 5 ultrasound features that have given category in this: multilocular, solid areas, evidence of METs, ascites, and bilateral. So each has given a score 111 score. And finally, if we take out the score, if the cutoff level is taken as 200 in RMI 1, 2, and 3, but in RMI 4, there is a 4th feature also added, that is the size of the cyst. So if it is cutoff level is 200, if it is less than 200, then we can make it as a benign lesion. If it is more than 200, then it is a malignant lesion, and it needs the proper CA ovary treatment. Next. According to NICE recommendation, RMI 1 should be calculated in women with suspected ovarian malignancy, and it has a sensitivity of 78% with 87% specificity. Next. If we combine both ultrasound and CA125, so the studies have done that screening can be done with these markers, ultrasound and CA125, but it is not currently recommended by any professional society, and no literature till this date have not recommended by screening by this method. Screening may increase the likelihood of diagnosis at an early stage, may lengthen survival with ovarian cancer, but screening did not improve ovarian cancer related mortality. Next. The harms of this using ultrasound and CA125 are that there's a 44% chances of false positivity with unnecessary stress and unnecessary surgery in 3.2% of patients, leading to complications in 15% of falsely positive surgeries. Next. Then there is to get this over, the new algorithm was made that is called ROCA algorithm, risk of ovarian cancer algorithm, in which it is made for postmenopausal women, in which we used to do the CA125. There's usually a scaling of CA125 done, and gradually we used to take as monthly, or there's a marker CA125 is taken, and it is used as CA125 based screening test. But it has shown that it is also not significantly different from but there is no increase, but it is not very specific. So it was studies by UKC TOX trial, but ovarian cancer related mortality was not significantly different from the unscreened population. Next. studies in high-risk patients have also shown that screening with CA125 and transvaginal ultrasound may improve the likelihood of diagnosis at an earlier stage and may improve survival. Screening is, as we show that there are certain high-risk factors like BRCA mutation, if there's a family history of breast or ovarian cancer, then apart from screening, risk-reducing salpingo-oophorectomy is generally preferred. Next. Then next, third marker is our HE4. HE4 is produced by human epididymal epithelium, and it is a specific for CA ovary, as we have seen that CA125 can be raised in other inflammatory conditions or in other non-gynecological conditions, but HE4 is specifically specific if it is raised in usually malignant CA ovary. So its reference rate is 60 to 150 picomole per liter. It is FDA approved for monitoring of recurrent disease, but it is still not approved for screening purpose. Most common source of false positivity is renal failure. Next. But HE4 is more sensitive and specific than CA125. Its sensitivity is 72% and specificity is 95%. And it has fewer false positive results with benign disease, not enough substantial data to support the use. Next. These are the European guidelines recommendation, and they recommend that HE4 measurement either alone or in combination with CA125 may be considered for differential diagnosis of pelvic masses, especially in pre-menopausal patients. So it is, if already there is a mass, then we can differentiate to how to approach it as a benign or malignant, but still it is not for screening purpose. Next. Then there's another is a Roma index that combines already I have told that HE4 and CA125 and menopausal status. These three things are combined, and it has cleared FDA approval in 2011, and it is indicated for women more than 18 years with adnexal mass who are planning for surgery. It is not a screening or standalone test. Next. The cutoff for Roma score in premenopausal is more than 1.31 and postmenopausal is more than 2.7. You can calculate Roma score there's an app available online, freely available, and you can calculate Roma score of any patient. Its sensitivity is 100% premenopausal patients, and postmenopausal it is 92% sensitive. Next. Other markers are also studied, but they have not such role like mesothelin, B7H4, decoy receptor 3, and spondin 2, but they are not studied too much. Next. There are two, recently there is more of boom like OVA1 and OVA2 score. So these are the multivariate index assay, which are used basically to differentiate to mass is benign or malignant. OVA1, it has there are 5 biomarkers that are present in OVA1. If they are checked, if there's a score, if it came out to be low risk, then we can say it is a benign. If it came out to be high, then it is a malignant. But if it is an indeterminate score, then we find that we have to perform OVA2, or commonly called OVERA. Next. The 5 markers which are in OVA1, there's are the apolipoprotein A1, beta-2 microglobulin, CA125, and prealbumin and transferrin. So 2 markers are raised, that is beta-2 microglobulin, CA125, and rest markers are down. So it is basically, it has a 98% negative predictive value and 56% sensitivity. So these are, OVA1 is supported by ACOG, SGO, and NCCN, both support, but it is just for to diagnose, to differentiate the mass. Next. Then the OVERA score. In OVERA score, 2 markers are different. That is FSH and HE4 are included in it. And it has OVERA performed with the OVA1. If OVERA is performed, if OVA1 results came into indeterminate range. So next, it is also FDA cleared. Next, we have risk-reducing surgery. That is, I have told you already, in high-risk patients, we can perform risk-reducing surgery. So like BRCA, high-risk patients, like if there's a BRCA mutation or there's a Lynch syndrome, or there's already a first or second degree relative that are in the family. So we can go for risk-reducing surgery. So it is risk-reducing salpingo-oophorectomy. So the main protocol of this surgery is that it is a minimally invasive laparoscopic surgery, includes a survey of the upper abdomen, bowel, omentum, appendix, and pelvic organs, as we do in our staging laparotomy. And then if there's any abnormal peritoneal finding, it should be biopsied, or pelvic foraging should be taken as already it is done in a staging laparotomy. Next. The procedure should include total BSO, total bilateral salpingo-oophorectomy with 2 centimeters of infant pelvic ligament should be tied, and fallopian tube should be cut up to the cornua. And all the peritoneal surfaces, including the ovaries, tubes, peritoneum underlying area, between the tube and ovary and the pelvic side wall, it should be removed simultaneously with that tubo-ovarian mass. Next. Minimal instrument handling of the tubes and ovary should be there. Ovary should be placed in an endobag for retrieval from the pelvis. And it has seen that in high-risk patient like in BRCA1 or BRCA2, half of the cases of occult disease identified by RRSO. And next, for pathologic assessment, it is called a CFIM technique, that you have to do the serial sections from the femoral end of the tube, and you have to evaluate it very thoroughly. Because more chances, because currently, as we know that currently it has shown that the epithelial ovarian cancer, usually the nidus is from the tube. Fallopian tube is the nidus, and it got into the ovary epithelial surface and it got implanted there, and it will retain later into malignant masses. The ovary should be carefully sectioned, processed, and assessed. And if occult malignancy or stick is identified, stick is basically, it is a tubal intraepithelial carcinoma, that is a pre-malignant lesion for ovarian cancer. So it should be, then if it is found, it is to be referred to gynec-oncologist. Next. Based on studies, specifically if we found that the patient, that there's a history of Lynch syndrome in the family, or patient has a MSH or any mismatch repair, if mutation is found, then it is said that hysterectomy can also be done along with the salpingo-oophorectomy. Next. In premenopausal, if patient has a history of premenopausal primary breast cancer, a prophylactic BSO plus hysterectomy, it also reduces the risk of primary breast cancer and improve breast cancer associated mortality. Next slide. If salpingectomy, just like if we are considering in premenopausal patient, and if ovary to be saved, or if there's any fertility concern, if only salpingectomy alone is considered, the fallopian tube from the femora to its insertion should be removed. The fallopian should be carefully examined. Next. Now, what are the risk of these? It's risk reducing salpingo-oophorectomy. It can be caused that common risk that is injury to the bowel, bladder, ureter vessels. And those who are premenopausal and those who are postmenopausal, there is a risk of menopausal symptoms may emerge, re-emerge, or worsen. And there's a long-term impact on quality of life and sexual functioning. Next. It has shown that it's common that we all know that premenopausal, if it's earlier menopause, it causes a risk of certain cardiovascular conditions, COPD, arthritis, asthma, osteoporosis, mental health conditions. Next. Stick that I've already discussed earlier. Stick, it is called serous tubal intraepithelial carcinoma. It is a precursor of most high-grade serous ovarian or peritoneal cancer. Observation alone with CA-125 monitoring and surgical staging is there. Next. Now, the take-home message is routine screening is not currently recommended by any professional society. The literature does not support routine screening for ovarian cancer in the asymptomatic general population. If there are high-risk factors like BRCA mutation, family history of breast or ovarian cancer, risk-reducing salpingo-oophorectomy is generally preferred over screening. CA-125 is recommended not for screening. It is just for monitoring purposes only. Next. USG is a basic and important radiologic tool in diagnosis and triaging for ovarian cancer. Biomarker test and prediction algorithms are for assessing the likelihood of malignancy among patients who have an adnexal mass, who haven't not had got for surgery. These are not for screening purposes. And these tests are for preoperative assessment only, and none is suitable for ovarian cancer screening. They are also not for use as a standalone diagnostic test. Thank you.
Thank you, Dr. Roli. It's a nice explanation regarding carcinoma ovary diagnostic as a diagnostic tool, how to diagnose this carcinoma ovary in early stage. Starting from ultrasound, ROCA, T4, lot many thing over 1, over 2, over a score, So there are so many things to come up recently. Now I'd like to have comment from Dr. Deepti Chaturvedi. Dr. Deepti.
She has already commented. She has already commented. Finally, what is it? Only ultrasound. Rest all the markers are for follow-up. Ultrasound is also not routinely done for screening. Okay, if you have an adnexal mass, you can go for ultrasound and go just for assessment prior to any surgery. And MRI and CT से भी अच्छा ultrasound है. That is what is her message, isn't it?
Yes, ma'am.
Good. So, very well said. Very nice informative. And Kristen, these days, all are going for preventive oncology because we are not able to get early diagnosis of ovarian cancer. So take home messages, high risk patient, only the high risk patient or patients with adnexal mass or those who are under stress who come for ovarian, for ultrasound like PCOD and all, they think that they are having some cyst or whether it is malignant or benign. So we can add up the other biomarkers and do the scoring for our own confirmation when we are ourselves in doubt. Though it is, you have very nicely said about the scores, ultrasound scores, just like the BIRAT of the breast cancer. So, too about this. That's very nicely said. Thank you so much, Dr. Roni. It's really a pleasure having you with us. Thank you so much.
So thank you.
Mm,
Thank you, Dr. Deepti.
mm.
And we have diagnosed the case. Now the question is of treatment of ovarian cancer. We have treated the case. Now comes the relapse. Because as you know, 70% of ovarian cancer, they relapse within 2 years in spite of definitive surgery and chemotherapy, first line chemotherapy. So now on that topic we are having our learned speaker, Professor Gaurav Gupta. He will be speaking on relapsed carcinoma ovary. Dr. Gupta is DM Medical Oncology from TMH Mumbai, PCMO, MD Medicine and MBBS from GSBM Kanpur. His current designation is Director, Optimus Oncology Center, Lucknow. He was ex-head and founder, Department of Medical Oncology in RML, Lucknow. Ex-specialist registrar at TMH Mumbai, ex-senior resident AIMS New Delhi, ex-senior resident Rajiv Gandhi Cancer Institute New Delhi and Safdarjung Hospital New Delhi. He did his MBBS from SN Medical College Agra, MS from So now we invite Dr. Gaurav Gupta for his talk on relapsed carcinoma ovary. Dr. Gaurav Gupta, please.
Good evening, sir, and thank
Good
you
evening.
for having me here. I'll start sharing my slides. So I hope it's visible to you all.
Yeah.
So, all right. Just a minute.
It's visible.
So I will not be covering non-epithelial ovarian cancers and real cancers in this talk. I'll only be talking about the epithelial ovarian cancers. So we have already discussed this thing. I don't think there is any need for talking about it again and again. So the first question is when to treat. So most of the recurrences, most of the times we follow the patients and check the CA125 levels. And if it is raised or there is a serological relapse, we think whether we should treat or not. So there is a very nice study which shows that just based on CA125 levels, if the patient is asymptomatic, there is no need to treat. because it doesn't improve the overall survival of the patient. So currently, as the author concluded, that the study provides no evidence that early initiation of chemotherapy because of a rising CA125 improves survival or quality of life compared with delaying chemotherapy until signs or symptoms of recurrence occur. So it is very important that we should remember to ask for symptoms and look for radiological signs of recurrence before initiating any sort of therapy in these patients. So the other thing which is very important is platinum resistance. So it is based on platinum-free interval. Traditionally or historically, it has been divided into 3 categories. Platinum refractory is when progression occurs during treatment with a platinum-based chemotherapy or within 4 weeks of treatment completion. These patients tend to do poorly with a very small survival of 3 to 5 months. And platinum resistance is approx 6 months, whereas platinum-sensitive disease is said to be there when the treatment interval is more than 6 months. These patients usually have a decent overall survival of 2 to 3 years. However, we should remember that this is not something which is a compartment. It is a continuous curve, and the results tend to improve as the treatment-free interval goes on increasing. This is the natural history of disease. We all know it very well. Multiple relapses. Patient will have multiple relapses, which may be platinum sensitive to begin with, and later on, he will have platinum resistance relapses, and ultimately, there will be death. So how to choose a regimen? There are multiple factors that need to be taken into consideration, like therapy-free interval, number of lines of treatment, and the response to previous treatments, the rate of progression, number of sites of progression, ascites present or not, what is the histological subtype, presence of BRCA mutations or HRD or now MSI also, and what is the condition of the patient, what is the age, comorbidities, etc. Along with it, we need to look at the toxicity profile of whatever previous treatments that patient has had, and then we should take into consideration patient preference and doctor's preference before zooming into a particular therapy. So I'll divide my patients into patients who have a platinum-free interval of 6 months, or we can call it as cases where platinum is an option. So in these patients, treatment can be with a monotherapy with any platinum-based agent like carboplatin or cisplatin, or a doublet of carboplatin or cisplatin with another drug. This slide just sums up the results of these therapies. Most of the times, we get a response rate of 30 to 60 or 70% with these therapies, and the progression-free survival is approximately 7 to 13 months for these patients. So there were studies done to compare whether there is benefit of adding a second agent to platinum, and it was seen that there is a benefit of adding either paclitaxel or gemcitabine in terms of progression-free survival in these trials, and a small benefit on overall survival with addition of paclitaxel. But with gemcitabine, this benefit in terms of overall survival could not be ascertained. So there are multiple doublets. So this study was done to look at whether pegylated liposomal doxorubicin is better or non-inferior versus use of paclitaxel in combination with a platinum. So in terms of PFS, there was a little bit benefit of adding of PLD as compared to paclitaxel, which was a numerical benefit of approx 2 months. However, in terms of overall survival, there was no significant difference. And if you look at the non-inferiority p-value, it was non-inferior. These two regimens were non-inferior. So either of the two regimens can be used depending upon the toxicity profile and the patient preference. There are cases where platinum cannot be used, maybe because of some hypersensitivity reaction or some other issues. Suppose patient has renal failure and has developed hypersensitivity reaction to carboplatin. In these cases, we can use a non-platinum doublet. So this study was done to look at whether if we compare carboplatin with liposomal doxorubicin to liposomal doxorubicin plus trabectedin, does it make sense or not using these tests? So the results showed that this is considered with carboplatin and PLD. There was no difference in overall survival. However, trabectedin-based combination was very much more toxic in terms of hematological, gastrointestinal toxicities, as well as weakness, ischemia, and hepatic toxicities. So this regimen has not gained much of use in practice as such. Then came the role of bevacizumab. Addition of bevacizumab was tried to a doublet-based regimen, and it was seen that when you add bevacizumab to carboplatin and gemcitabine, there was a benefit in median PFS that was of approximately 4 months. However, there was again no benefit in terms of overall survival. Another study showed the similar results with the addition of bevacizumab to carboplatin and paclitaxel. Again, median PFS improved by 3.2 months, but there was no significant difference in the overall survival. There was another study which compared whether choice of chemotherapy backbone matters or not. They compared carboplatin with gemcitabine versus carboplatin PLD in addition of bevacizumab. And they showed that probably PLD is a little bit better than gemcitabine as a partner for bevacizumab. However, we should note that these numbers are very small, 1.7, and we have seen bevacizumab does this in most of the places it is used. It increases the survival by a couple of months. It doesn't change it very significantly. So later on, we tried adding PARP inhibitors to the therapy. In second line, after treatment with a doublet, if the patient is in remission, he has achieved a partial remission or maybe a CR, in that case, adding a PARP inhibitor as maintenance therapy, it was studied in these 3 studies with different PARP inhibitors. Solo 2 was with olaparib, Nova was with niraparib, and Ariel 3 was with rucaparib. Consistently, all 3 studies, they have shown that addition of a PARP inhibitor as maintenance in the second line leads to a reasonably good progression-free survival with a hazard ratio which is approx 0.3 in all the 3 trials, and the progression-free survival duration is increased to the tune of approx 16 to 20 months. So this is important. And if the patient has not yet really used PARP inhibitor in the first line, he should definitely be exposed to PARP inhibitor, especially if the patient is a BRCA mutant. Also, there is evidence to use PARP inhibitor in non-BRCA mutant patients through the NOVA trial. In this trial, again, when subgroup analysis was done, for non-germline BRCA mutated patients, there was benefit. For HRD positive patients, there was again a benefit of adding PARP inhibitors. And importantly, in the HRD negative subgroup also, that is non-germline BRCA negative and HRD negative patients, there was again a benefit, although this benefit was not as robust as in the other groups, but there was a slight benefit of approx 3 months or a progression-free survival benefit in this subgroup also. So to summarize, in platinum-sensitive relapses, platinum doublet is preferred over platinum-based monotherapy through these trials. There is no or only small difference between the platinum doublets. So any of the 3 doublets can be chosen based on the factors that we have already discussed: carboplatin paclitaxel, carboplatin liposomal doxorubicin, or carboplatin gemcitabine. If PARP inhibitor was not used in the first line, add PARP inhibitor as maintenance therapy based on any of these trials. And if bevacizumab was not used in the first line, we can add bevacizumab upfront to the doublet regimen also. So the other subgroup is where the platinum-free interval is less than 6 months, or in cases where platinum is not an option. So if we again look, the platinum refractory patients have a dismal outcome of just median overall survival of 3 to 5 months, whereas platinum resistant, they do have a reasonable outcome of 9 to 12 months. So in this setting, only single agent chemotherapy is usually recommended, and most of these therapies, they have a response rate which ranges from somewhere around 25 to 35% most of the time. So paclitaxel weekly, paclitaxel 3 weekly, liposomal doxorubicin, topotecan, gemcitabine, all these have similar sort of response rates. And the median progression-free interval is just around 2 to 7 months. So just up to 7 months of progression-free survival benefit. This is not very great. So bevacizumab was added to look whether it helps in increasing the survival or not. So again, this study, Aurelia study, which used weekly paclitaxel, topotecan, or pegylated liposomal doxorubicin in combination with bevacizumab, which was approx in a high dose, and this showed again a benefit of 3.3 months. If you remember this figure, 3.3 months, we also saw similar benefit in platinum-sensitive relapses in terms of progression-free survival, where it was approx 3 to 4 months of progression-free survival benefit. And there is no significant overall survival benefit. So that's why many times it is debated whether we should add bevacizumab in the platinum-sensitive relapses, or rather we should wait for the patient to become platinum refractory, where there is no much available therapies, and use bevacizumab over there because it increases the PFS to the similar value, and it also tends to improve the response rates of single agent chemotherapy. Apart from that, oral metronomic therapy is something which is used by many of us in India in both the platinum sensitive, but majorly in the platinum refractory setting, and many different type of regimens are in use. This is one analysis from AIMS. This is for almost 38 or 40 patients, if I remember it correctly, and they have used multiple type of regimens where pazopanib and etoposide based regimens were commonly used. So they said that the overall response rate was approx 50%, which is quite great. But then this figure is for both platinum sensitive as well as refractory patients. And the median PFS was 8.2 months. And the overall survival was 38 months. So this oral metronomic result is decent, but then we should keep in mind that this is not separately for refractory patients or for sensitive patients. There are other regimens also which are in use, like cyclophosphamide, etoposide with tamoxifen, and many other things like cyclophosphamide with pazopanib alone. So these all can be used. For platinum refractory or PFI less than 6 months, to summarize, single agent paclitaxel, PLD, topotecan, and gemcitabine, anything can be used. Overall response rates to range of 5 to 35 months and median PFS of 3.5 to 7 months. If possible, you should add bevacizumab. It will increase the PFS as well as the response rate. And we are looking forward to newer regimens and participation in trials. There are certain other molecules which have come up recently, but nothing very promising. I'll just name a few later on. The other thing is immunotherapy. Many people ask, what is the role of immunotherapy in ovarian cancer? So for monotherapy, it has been dismal results. Overall response rate was not great, stable disease only in 25 to 40%, and with a duration of response of 8 to 16 months. Combination with chemotherapy, it did not make any difference when immunotherapy was added to paclitaxel or avelumab. Chemo plus anti-angiogenic plus immunotherapy, again, results are dismal, no difference across 2 different trials. So this is again something which needs a lot of work. Monotherapy obviously is broken, it doesn't work. trials are underway for chemo plus PARP inhibitor plus IO plus minus BEV, that is multiple agents together. And there are multiple new approaches using double IO and other newer drugs that probably will help us in the future. So there's a little bit which I'll say about role of surgery, which is often neglected in relapsed ovarian cancer. So this is one landmark study, desktop 3 study, platinum sensitive to patients, and they randomized it to cytoreductive surgery upfront versus no surgery followed by chemotherapy. They showed that outcome-wise, overall survival in the whole group was better. In subgroup analysis, patients who had no surgery versus surgery, and the result which resulted in complete resection, there was a difference of 15.9 months, which is huge. And in patients who underwent surgery arm, that is surgical resection, those patients who had residual tumor versus those who had complete resection, there was a huge difference of 33 months. So probably the patients who had residual tumor, they had inferior outcome because in this case, effective systemic therapy was further delayed. So to summarize, for surgery, there's level 1 evidence for PFS and OS benefit in patients undergoing secondary cytoreduction versus chemotherapy alone. Well-defined and validated selection scores are available, and algorithms are available to identify these surgeons. And there's no role of HIPEC on new adjuvant chemotherapy in secondary cytoreduction. In palliative cases with bowel obstruction, surgery may be considered. High expertise and multidisciplinary team is required for this. This is the current NCCN guidelines. As I said, there are certain new agents that they have included, like all these darbepoetin, entrectinib, selpercatinib, but these are all exploratory therapies. Nothing is very much approved or very much effective in this. Docetaxel is again an immunotherapy drug which is being tried in these tumors, and in this NCCN it has been included just because of a single arm study. There's nothing great data about these studies. This is the drugs which can be used in refractory setting. There is a drug called mirvetuximab. This is a folate receptor antagonist. However, there is a single study which shows that it is probably beneficial, a phase 3 study which shows this does not work. And even in the single arm study which has shown that it benefits, there is high toxicity. So this is again not something which is very much established. So I should end my talk with this beautiful picture of a cell which was taken by NASA. And I will thank you all for your patient listening. Thank you.
Thank you, Professor Gaurav Gupta. Such a nice explanation regarding relapses and resistant tumor, in fact. And doublet, starting with doublet, single agent chemotherapy is out of question. So people are using doublets, then keep on adding on bevacizumab or olaparib or PARP inhibitors if they are not used earlier. Cytoreductive surgery after in relapse cases, I don't know how far it is, but it works somewhere. I don't know what is the overall survival, but it works.
So again, the problem is most of the surgeons also don't prefer doing a secondary surgery.
Right.
Low volume or where there's no peritoneal disease, that is the setting that most of the surgeons are comfortable doing it. But if you go to the desktop trial, they have done surgery in patients who have peritoneal disease, ascites, but then they have their OVAR, this criteria which must be fulfilled before they take up the patient for surgery.
I don't know. Earlier, the total peritoneectomy was not there. So I don't know. The further trials, I don't know whether they have done it earlier or not. I think it was not earlier. It is coming for the last 4 or 5 years. So the results which were compared, we are still in dark. So we are waiting for the results, and the overall survival will be decided later on by this. And what I think is, whatever standard chemotherapy you are following, and in case of relapse, you have to change entirely the drugs which you have already used. You can go for the newer drugs rather than repeating the same. even if it is sensitive, platin sensitive tumor, even if it is that, you should avoid those. After giving certain second line of treatment, then you can again come back to the same thing, and that will give you a good overall survival.
True.
This is I've seen in many cases.
Yes, true.
So very nice topic and explanation about the relapsed carcinoma ovary. Thank you very much. If there is any question from the audience, please put it in the box. Dr. Deepti, is there any question?
Yes, Ankita.
There are no questions from the audience, ma'am.
Okay. No, I thought you would be later. Anyway, if there are no questions, then we can just conclude with
Okay.
the switch off yours. So I was saying this, that finally I wanted a very clear, crisp line, like what should be done in case of relapsed ovarian surgery, or just a mixture of all these therapies that he has mentioned. Like second look, patients are very anxious, and GC is also so poor that they are very poor operative risk patients. Like we say, debilitated and comorbid condition, low GC, they're very poor operative risk for an abdominal surgery. So, and then you talk about the drastic surgery, such a cumbersome and aggressive surgery, means like you have to take out so many limb and then put HIPAC, and it takes around 12 hours. And then who knows, depends on the anesthetist if he's an expert to deal with low GC for so many hours. And what about the recovery? The result should be drastic, then it's okay. But if the result is nearly the same, so I think so medical oncology takes over the surgical part, and
That
it
is
should be done.
where the role of surgeon comes in. He needs to be very clear about the inclusion criteria and the selection.
Yes.
There are multiple studies which have been done. So the desktop was the first study which came out. This was in, I think, 2014. After that, 3 studies have been done, or rather 2 phase 3 studies have been done, out of which 2 studies are positive, 1 is negative. And 1 is negative only because it took very low risk patients and they had no clear-cut criteria or scoring system to assess that this patient should go for surgery. So like in desktop, they have taken only performance status 1 or 2 patients with a platinum sensitive relapse, not a platinum refractory relapse, with certain other things like ascites should be less than this volume. So there are criteria for that. If you go by those criteria, the results themselves say that the overall survival is better by 20 months.
Okay.
20 months is a huge number.
Huge number, but by your medicine or by surgery?
That is surgical. The addition of
Surgical.
surgery. Yeah,
Then
that-
see ovary, there is always, as far as we can go, we have to go for surgery. It is the primary thing that we can do. The debulking is the primary thing that we have to do in cancer ovary.
No, that's so debulking was done.
But in
Now it is actually not debulking, but it is
cytoreductive surgery. It is called CRS.
cytoreductive surgery.
So CRS
But
and
what
HIPAC.
about HIPAC? That is also done. You were telling
There is-
HIPAC has no
again, there is
important
no role
role.
of HIPAC. Secondary surgery.
Dr. Gaurav Gupta, if you can hear me,
Hello?
can you?
Yes, ma'am.
Ma'am, studies are showing that without even HIPAC, if we are doing CRS and we are not giving HIPAC, then there is no role of CRS. We have to combine HIPAC with CRS.
No, I strongly disagree with this.
Please,
If we are talking about relapse setting, there is no study which has shown any benefit of HIPAC or PIPAC for that matter.
yeah, okay. In the relapse studies and in the early cancer or early ovarian cancer, we can go by HIPAC.
So again,
But
early ovarian
HIPEC,
cancer, there is no role.
HIPEC has a role in early or not?
No. So upfront setting, early ovarian cancer, there is no role. For advanced ovarian cancer,
Yes.
there is a controversial role because there is one phase 3 study
Okay,
which
so we should talk about HIPEC in ovarian cases with ovarian. Huh? That's clear.
No, it's true. Sir is saying true that in primary settings we can go for HIPEC, but in secondary settings like in recurrence, there is
Even
no,
in primary, is saying there's no role.
man, primary beyond stage 3 there's a role of HIPEC.
That also is saying no.
so it is
No, there's a
controversial.
one trial and there are multiple trials are there. Sir, since 2018, there are 3-4 trials are there.
There are only 2 trials, phase 3, which have shown benefit. One is
Yes,
the
sir.
trial, and the other was
Yes,
the
sir.
The Indian trial showed there is some benefit, but then there were multiple issues with that trial, so it is not accepted worldwide. The second trial, which has been recently come, it failed to show a benefit of HIPEC. So again, till date, HIPEC is something which is exploratory.
Yes. It's costly also.
Yes,
10 to 12
costly,
lakhs.
cumbersome, everything.
Yeah, and takes so much time and patient. He can't tolerate such a big surgery. She can't tolerate. So anyway, it was a good discussion, and thank you so much for both of you for the lively session and very innovative, interactive, and informative and elaborative too. And many things were highlighted academically, though practically again we are at a dim what to do. So for early diagnosis and relapse and surgery, still we are in doubt, and we will see with the next researchers what they come up with and continue to keep upgrade ourselves and abreast ourselves with the new knowledge, whatever is in view, and it comes up, we'll be following that, all the guidelines. Thank you, everyone. Any questions, any doubts, or should we leave the session?
Thank you, ma'am.
Thank
everyone.
you, Clarinet, for your
you.
technical support. Thanks,
And-
Dr. Roli, and thanks, Dr. Gaurav Gupta. Thank you, Dr. Chaturvedi, for hosting this session. Thank you all.
Thank you for extending us the
Okay, good night.
opportunity to host this
Okay.
session.
Thank you,
I
ma'am.
hope you had a seamless
Thank you.
experience. So with all your permission, I'm closing the session today.
Okay, thank
Okay.
you.
Thank you so much. Thank you. Thank you.